Dear chairs and the colleagues, today I'll try to talk about the assessment of paravalvular leakage and what we do as an imager in the Cath lab. Let's start with the definition of paravalvular leakage. Paravalvular leakage is the regurgitation jet passing through the channel between prostatic valve and the native cardiac tissue. We commonly see in the PVL in the mechanical prosthesis and at the mitral position. 1 to 5% of the PVLs have clinical significance. When we look at the etiology in the early after the surgery, we commonly see the surgical technique as an etiology. On the late onset, the infection and the annular calcification are the reasons of paravalvular leakage. Patients can be asymptomatic or they may develop heart failure, hemolytic anemia, and infective endocarditis. Large defects lead LV volume load, which end with heart failure. The small defects lead turbulent flow, mechanical trauma, and hemolytic anemia. And also turbulent flow is the reason of infective endocarditis. In the diagnosis with physical examination, actually with inspection, we can get a lot of information. We can get the heart failure symptoms, and with the hemolytic anemic patients, we can get the icteric color due to the increased indirect bilirubin levels, and with auscultation, we can hear holosystolic murmur and mitral paravalvular leakage, and in aortic paravalvular leakage, we can hear diastolic decrescendo murmur. Also in laboratory examination, we can detect the hemolytic anemia. What we see in hemolytic anemia, the reduced hemoglobin and the haptoglobin levels, and increased LDH, reticulocyte amount, and indirect bilirubin. And due to heart failure, we can see an increased NT-proBNP levels. But for sure, the gold standard diagnostic test is echocardiography. We'll start with transthoracic echocardiography. As you can see, it's an apical four-chamber view, and we have a prostatic mitral valve, and in the medial aspect near to intraarterial septum, we have a paravalvular regurgitation. But it's not always that much clear, that much easy to see the defect and the regurgitation flow due to acoustic shadowings or vibration artifacts. What should we do at that time? We should go with the indirect signs. What are the indirect signs? For mitral valve, increased peak mitral velocity, increased VTI ratios of mitral valve to LVO, mean gradient more than 5 millimeter mercury, or increased TR jet velocity. All of them are the indirect signs of PVL. So when we are suspicious about the PVL, we should go with transesophageal echocardiography. And for aortic PVL, a transthoracic echocardiography is okay for anteriorly located ones, but posterior PVLs need transesophageal echocardiographic examination. And also, as in mitral valve, we have some indirect signs for PVL. So if we have the suspicion, again, we should go with TEE. What we do as an imager, we have a lot of role actually. We start from the diagnosis, the preoperative phase, and then we have really an important guiding role during the operation, and After the operation, we should check the success and the complications of the operation. So let's start with preoperative phase. Actually, maybe this is the most important point because we are telling the surgeon or the interventionist where the problem is, how severe the problem is, and then the operator construct the operation or the procedure in his mind according to what we are telling. So what should we give as an information to the operator? We should give the severity, the localization of the defect, shape, number, size of the defect, and the condition of intraarterial septum, especially in the mitral pvls, and the contraindications. We will go one by one. The severity, as you know, the quantitative measurements are not validated in pvls. We can give the volumetry volumes, or the easier one is defect length to annular ring length ratio. If it's less than 10%, it's mild. 10 to 20%, it's moderate. If it's more than 20, we can call it as a severe regurgitation. So if the ratio is more than 40, we should say that this prosthesis is unstable. Localization is important because, as I said before, the operator construct the operation according what we are saying. So we should give the exact localization to the operator so he can imagine where is the defect and go through the defect. So according to the localization, the operator choose the access approach. So we are to talk the same language with the surgeon or interventionist. We are using an clock scheme, as you can see here. This is an LA view, left atrial aspect, the NFOS view, or we can say the surgical view. We see the mitral valve from NFOS, and we put the aorta at 12 o'clock position when the aortic valve to 12 o'clock position. When the aortic valve is at 12, the left atrial appendix at left hand side at 9 o'clock position and then laterally, and the intraarterial septum will be in the right hand side at 3 o'clock position. These are our landmarks. We are orienting ourselves according to these clock positions. So aorta will be in 12, LAA will be 9, and the intraarterial septum will be in right hand side at 3 o'clock position. As I said, LA view, surgical view, and the NFOS view, they are all same. We are looking mitral valve from up to the down, and the aorta will be on the 12, and LAA will be in 9, and intraarterial septum will be 3. So we can easily say that the defect is at the position of 2 to 4 maybe, and then the surgeon can easily understand that it's close to intraarterial septum. It's in the it's in the medial aspect. So but in fluoroscopic view, it's something different, because the fluoroscopic view is left ventricular view. We are just looking under the valve, okay? So again, if we put the aorta at the 12 o'clock position, aortic valve on the 12 o'clock position, this time intraarterial septum, which located medially, will be on the left-hand side, as you can see at the left bottom figure. And the left atrial appendix will be on the right-hand side. So in the fluoroscopic view, as you can see here, the aortic valve at the 12 o'clock position, LAA in the right-hand side, which is actually located at 9 o'clock position, and the intra-atrial septum will be on the left-hand side. So we can say that surgical view and the 3D T views are similar, but they are different from fluoroscopic views. So surgical and 3D are the mirror images of the fluoroscopic view. For aortic pvls, we put the interarterial septum at 10 to 11 position. Again, we are using a clock system. And the 12 is posterior, 6 is anterior, 3 is lateral, and 9 is medially located. When we go with shape, number, and size, they are important to choose the device and how many device we will use, which shape, and what should be the size. So as you can see here, the defect can be round, oval, or the concentric. So we cannot use the same devices for the different types of defects. As you can see here, we have different devices like vascular plaques, ASD, the device for ASD, device for VSD or PDA closure, and the 7th and the 8th one are dedicated for PVLs. They are specialized for PVLs. So according to the size, shape, we choose one of these devices. And the gain is important in the sizing because, as you know, if we increase the gain too much, we just underestimate the defect, as in the left-hand side movie. If we decrease the gain too much, this time we just get rid of the native tissue and we overestimate the size of the defect. So what should we do while maintaining the gain? We should go with 2D actually. We should optimize the gain at 2D, then we should convert the image to the 3D, not making and optimizing at 3D images. First, we should go with 2D optimization and then go to 3D images. And also, I want to say that the 3D color Doppler is important here because we need to have a high frame rate. To get the high frame rate, we should increase the acquisition beats. As you can see here, we have the beats 6 and the frame rate is 15. It's a good frame rate. And we shouldn't make a measurement on the direct 3D images because it can underestimate the size. So we should go to NPR mode and we should make the planes perpendicular to each other, and at that time we can get the exact size and the shape of the defect and make the measurement on the NPR mode. Here you see an 1 beat acquisition, but we narrowed the sector, so the frame rate is 13, as you can see here. It's not bad at all, so we can make measurements from these NPR views. Interarterial septum is important, especially for the mitral paravalvular leaks. As I said before, if the previous mitral valve replacements performed from a right atrium approach, we can be face to face with sutures in the intraatrial septum, so we cannot make a proper puncture. So the condition of intraatrial septum is important. It could be lipomatous hypertrophic or aneurysmal, or can be deviated to right atrium. So they all makes our puncture really harder. So also, before the operation, we should check the contraindications. What are the contraindications? Very large defects and the dehiscences and the thrombus and active infection. As you can see in the 2D images, the prosthesis makes rocky motion. It's so mobile, and we can easily see the swinging suture on the well. And in 3D images, we can see that the nearly half of, maybe more than half of the prosthesis is just detached. So for percutaneous mitral paravalvular leak closure, we have different approaches to get to the defect. The first one is antigrade transeptal approach. With this, it's shown in the figure A. With this approach, we can both get the lateral or the medial defects. And with retrograde transaortic, the figure B, we can just easily get the lateral paravalvular leaks. And with transapical, we can easily get both medial and lateral pvls. As I said before, the proper punction is important because for lateral pvls, we need to puncture from a little bit superiorly, and for medial pvls, medial mitral pvls, we should go a little bit inferiorly and posteriorly to reach the defect easily. And during the operation, our role starts with intraatrial septum puncture, and then we should confirm that the wire or the catheter crossed the true defect. And after the crossing the defect, we should confirm the proper placement of the defects without making any prosthetic dysfunction. And postoperatively, we should check the residual pvls and complications. What could be the complications? Prostatic dysfunction due to obstruction or central regurgitation. On the movie, we see that we placed a device near to 9 to 10 o'clock position, and this is a bileaflet mitral prostatic valve, and on the right hand side, leaflet moves very well, but the leaflet on the left hand side, it doesn't move. It's just stuck due to the device that we put there. So we caused a prostatic dysfunction. It could be one of the complications. Tamponade, device embolization, and thrombus formation could be the other complications. This is a nightmare. This patient is a 9-year-old, I think, and she admitted to our pediatric cardiology clinic. She had history of 2 times mitral valve replacement, and now she suffered from heart failure and hemolytic anemia. So our pediatric team decided to perform a percutaneous paravalvular leak closure. But as you know, as an adult clinic, we have a lot of experience, so they asked us to attend their operation. We attend their operation and we put an ASD device to the defect. Actually, it was looking good, but then it just started to swim in the LA, just going up and down and right to left, as you can see here in 2D images and the fluoroscopic views. So it was really a nightmare, but luckily we are an experienced team, so our interventionist not easily, but at the end catch the device, and we were safe at the end. Now I want to go with some examples, and the first one is medially located mitral paravalvular leak, and she was a 57-year-old female. She had history of aortic and mitral valve regurgitation. She had diabetes, hypertension, COPD, and the functional capacity was 3 to 4. And as you can see here, we have a mechanical prostatic mitral valve, and we have severe medially located paravalvular leak, and sorry for the movies. Yes, now it's working. On 3D images, as you can see here, we have the defect, the crescentric type defect, located nearly 2 to 3 o'clock position near to intrathecal septum. And during the operation, we can confirm that the wire and the catheter just passed through the true defect. And on the fluoroscopy, we can easily see that the defect passed through the just near to valves, and valves opening and closing very well, so no problem. And we placed the device, and there were no regurgitation, residual regurgitation. And in 3D image, you can see that we put an device, and the leaflets moves very well. And also in fluoroscopic view, we see that leaflets are moving and the device is just there. And this is a 35-year-old male patient, and he has a history of aortic and mitral valve replacement. And again, he admitted with functional cap class 3 to 4. And in last month, he had 2 times erythrocyte replacement. So as you can see here, he had a very severe laterally located paravalvular leakage, and the position is 9 to 11. And in transesophageal echocardiographic images, you can easily see that the wire had passed through the defect, both on 2D and 3D images, which located at the 9 to 11 o'clock position. We can easily understand that the wire just passed through that. But the operator who was just watching the fluoroscopic view said, Begum, you just missed the aortic paravalvular leakage before the operation, and now we passed through the aortic paravalvular defect. I said, no, it's impossible, because as you know, in 2D images and 3D images, we are just on the mitral valve. But he said, okay, just look the fluoroscopy. As you know, the bigger ring for mitral valve, and the smaller ring is for the aortic valve. So in fluoroscopic view, it really looks like we just passed near to aortic valve, but in echocardiographic images, you can appreciate that we just passed through the laterally located mitral paravalvular leak. So when the operator saw the T images, he was convinced, and we continued to our procedure. And the upper images shows we just pretend to put the device on the defect, but as you know, it's just moving. We couldn't fix it there, and we have a lot of residual regurgitation. But after some manipulations, we just put the device what we want, where we want to put exactly. So there was no residual paravalvular leak, as you see. And in 3D image, also you can see that we just put the device where we want to put its life, the laterally 9 to 11 o'clock area. But again, in fluoroscopic view, the device is just near the aortic valve. So again, he was a little bit, confused. But then when they change their position, we can easily understand that the device is just near the mitral valve. So both the imager and the operator were very happy at the end. And this is my last case, the aortic paravalvular leakage, a 61-year-old male, and he had history of CABG and aortic valve replacement, and he had diabetes, COPD, and the functional capacity was 4. So as you can see here, we have the leak at 11 o'clock position, and it's a severe PVL. On left-hand side, you can see the contrast images, both 2D and fluoroscopic views. On the right-hand side, the wire and the catheter just cross the defect. And we put the device, and there was just a trivial leakage, and we are happy with the result. The success actually depends on 2 factors, the technical success and the clinical success. The technical one is just placing the device into the defect without making any prostatic valve dysfunction. But the clinical success is the regression in the functional capacity or the improvement in the mechanical hemolytic anemia. Any decrease in the PVL provides clinical improvement if the patients go to operation due to heart failure. But if the patient's problem is hemolytic anemia, then the defect must be completely closed. If we just close a portion and then we just actually decrease the size of the defect, and the turbulation of the flow increases. So the increased turbulation cause increased mechanical trauma, cause increased hemolytic anemia. So there should be no residual leak for the patient who went to procedure due to hemolytic anemia. And also, the long-term efficacy depends on the residual leakage. Echocardiography plays really an important, a key role from beginning to the end, from diagnosis to the intraoperative guiding and the postoperative controls. In mitral paravalvular leak, 3D has an important role, but in aortic paravalvular leakage, 3D has some limitations. So the last sentence I want to say is the main success is achieved when the operator and the imager speak the same language and act together. Thank you for your patience.